Kiitoksia. Pääministeri Vanhanen, pöytää tuskin olisi voinut kattaa paremmin tätä päivää varten. Valitettavasti emme pääse keskustelemaan pääministerin kanssa, hänellä on erittäin tiukka aikataulu, mutta meillä on muuten runsaasti aikaa vielä tänään. Menemme eteenpäin ja haluaisin esitellä teille tämän aamun pääpuhujan, professori Michael E. Porterin. Michael E. Porter on maailman johtavia kilpailustrategian asiantuntijoita. Hänen tutkimusalansa ovat valtioiden ja alueiden kilpailukyky ja taloudellinen kehitys sekä kilpailuperiaatteiden yhteiskunnallinen soveltaminen esimerkiksi terveydenhuollossa, ympäristökysymyksissä ja yritysten yhteiskuntavastuussa. Professori Porter tunnetaan yleisesti modernin strategiateorian isänä ja erilaisissa arvioinneissa ja tutkimuksissa Porter on sijoitettu maailman vaikutusvaltaisimmaksi ajattelijaksi liikkeenjohdon ja kilpailukyvyn alalla. Porter hoitaa Harvard Business Schoolin Bishop William Lawrence-professuuria, joka on korkein Harvardin tiedeyhteisön jäsenille myönnettävä ammatillinen tunnustus. Vuonna 2001 Harvard Business School ja Harvardin yliopisto perustivat yhdessä strategian ja kilpailukyvyn laitoksen, jonka tarkoituksena on soveltaa ja syventää professori Porterin tekemää tutkimusta. Porter on julkaissut 17 kirjaa ja yli 125 artikkelia. Hän on suorittanut vuonna 1969 BSc-tutkinnon Princetonin yliopistossa ja vuonna 1971 MBA-tutkinnon Harvard Business Schoolissa. Hän väitteli tohtoriksi vuonna 1973 Harvardin yliopistossa. Erityisen mielenkiintoiseksi hänen läsnäolonsa tekee se, että hän kirjoitti noin vuosi 2 sitten kirjan, jonka nimi on Redefining Healthcare yhdessä Elisabeth Teisbergin kanssa. Ja tämä kirja tuo ihan uutta tuoretta näkökulmaa nimenomaan terveydenhuollon alueelle. Ja tässä yhteydessä olemme tutustuneet tietenkin hänen kirjoituksiin, ja nämä konseptit, joita hän siinä kirjassa esitteli, ovat edelleen kehittyneet viime aikoina. Ja hän onkin ollut aika monessa maassa ja monen maan terveydenhuollon kehitystyön eräänä asiantuntijana ja konsulttina. Muistan nähneeni muun muassa Ruotsista raportin, jossa hän oli mukana laatimassa suosituksia ja suunnitelmaa siitä, kuinka ruotsalaiset voisivat edetä omissa hommissaan. Ja nyt tällä kertaa me olemme jo tästä keväästä lähtien olleet hänen kanssaan yhteistyössä niin, että hän yhdessä sosiaali- ja terveysministeriön innovaatioyksikön päällikön Juha Teperin kanssa ja Juha Teperin apulaisten kanssa on valmistellut raporttia Suomesta, mutta käsittelemme sitä Suomen raporttia vasta vähän ajan päästä. Ensin päästämme professori Porterin kertomaan omia ajatuksiaan. We are particularly happy that Dr. Porter was able to dedicate some of his time to Case Finland. Now we will hear his presentation titled Redefining Healthcare, Creating a High-Value Healthcare System, Implications for Finland. Dr. Porter, please.
Well, thank you very much, and it's so terrific to be hosted here by Esko Aho, who is now an old friend, and we've been working for many years and talking about competitiveness and economic development, and we've had a chance to talk together. He's visited Harvard many, many times, and so it's a particular pleasure to be here with him in his own country. For a change, he usually comes to America. It's such a pleasure to see the ambassador, and thank you, Mrs. Barrett, for attending today's session. And it's such a pleasure to have all of you here, and I'm very honored by your presence. I understand how important this group is, and it makes me a little nervous how important this group is. And we're talking about a subject today that is a little bit different than the subject that those of you who know my work would have heard me talk about before. But I started on a journey about 10 years ago to try to apply what I'd learned about organizations and competition and management to the issue of healthcare delivery. And this has been a very arduous journey. I've spent a tremendous proportion of my time thinking about healthcare over the last 6 or 7 years. I've written a book, an entire book on the subject called Redefining Healthcare, which is quite a thick book, unfortunately. But it's a book that reflects the very large literature in medicine that I've had to try to learn a little bit about. I've gotten to know thousands of physicians. I've been to many of the leading hospitals and other healthcare organizations, not only in the U.S. and around the world, but also around the world. And what I'd like to do today is ask you to step back from thinking about healthcare in the ways that you've thought about it in the past. Because what I think we need to do here in healthcare at this moment in history, in Finland as well as in other countries, is that we can no longer assume that the nature of healthcare is going to be the same as it's been historically, and I'll talk a little bit about that later. I think we have to imagine a new kind of healthcare delivery system. And what I'd like to do today is paint a picture of what that new kind of healthcare delivery system might look like given today's technology, given today's knowledge, given our best understanding and knowledge that we have learned from many, many years and decades of work on the subject of healthcare delivery. I think the moment now in Finland is a good moment to think about this question. As the Prime Minister has mentioned and as Esko has mentioned, Finland's had a very great success in healthcare. Americans like me would love to have a healthcare system like you have. So I don't want any of you to think that I am arguing that you should look like the U.S. Quite the contrary. I think you've had a great success. You have a healthcare system that's universal and equitable. Everybody has access. You have a good primary health system. Everybody's covered. But what has happened in Finland is that more and more money has been put into the system over time, and we know that as we get older, that's just going to go up very, very rapidly if we don't change the way we think about healthcare delivery. The demographics are going to be very, very costly and very, very challenging. We also know in Finland that there's a tremendous shortage of doctors and medical personnel. There's not enough to deal with all the new demand that's coming. We can't just do things the way we have in the past. We have to think about how we could do them much, much more effectively. As the Prime Minister said, this is the time to think about a new model of healthcare delivery. Because the need for healthcare is going to go up and up and up over the coming years and decades. This is a good time to ask ourselves how we might take the principles that Finland has been so deeply committed to, of universal and equitable and excellent care, but apply those principles in a different kind of structure, in a different kind of system. It's this question that not only affects Finland, but it affects every single country in the world. I've had now the opportunity to work extensively in the U.S., of course, where we have almost a crisis. I've also worked in Germany, in Switzerland, in Japan, in Taiwan, in Brazil. Every healthcare system is facing these same challenges. And every healthcare system now needs to kind of rethink what the model of healthcare really looks like going forward. And it's this new conception of how we might look at the system differently that I'd like to share with you today. Last spring, I agreed with Sitra and with Esko Aho and his colleagues that I would work jointly with them to try to study the Finnish healthcare system and evaluate it and think about it using this new perspective. So we are in the process of developing an extensive white paper which will try to provide a sort of a very, very deep assessment of the system and make recommendations about how it might be changed going forward. And Jua Taperi will talk a little bit about more of the details of that white paper a little bit later this morning. But my job is not to talk too much about Finland because I'm not an expert. You are the experts. My job is to really talk about a way of thinking, a way of looking at the problem, a way of looking at the solutions that I hope will be stimulating, and I hope it will be useful, and I hope it will be helpful as you leaders in the Finnish healthcare system reconceive and improve on what you've already done. You've got a great system. The question is how to make it better. You've got a great system. The question is how to make it sustainable going forward. Now, I would argue that in order to transform healthcare and sort of address the future, we have to sort of reconceive of what the fundamental goal of healthcare system must be. Traditionally, I think many countries like Finland have defined their goals in terms of having a universal and equitable system, getting health care for all, providing access to care. And those are, of course, quite fundamental goals. And you've largely succeeded at those goals. In addition to universal access and equity, many countries have focused on cost as another critical goal, controlling the cost, because the cost of healthcare has a strong tendency to rise. And that's true as technology improves. That's true as expectations get higher. That's true as populations get older. So many countries spend a lot of time trying to control the cost. They control the cost by, hard bargaining with the drug companies to try to push the cost of drugs down, or shifting to generic drugs, or controlling the payments to physicians, or otherwise trying to keep those costs down. Many, many countries are very focused on cost control as they think about the goal of their healthcare delivery system. But what I have concluded is really we have to change the goal. We've achieved a universal and equitable system. We have to move from thinking about cost to moving about value. Instead of thinking about our goal as providing access and keeping the cost down, we have to rethink the goal as really driving up the value of the healthcare delivery system. I'm going to use the word value many times this morning in my remarks. What do I mean by value? What I mean by value is the health outcomes achieved by a patient per dollar cost. The health outcomes achieved per patient divided by the cost. The fundamental challenge in healthcare is value. Now, in our country, we're having a big political debate right now about healthcare, but our debate is primarily about access and about coverage. Coverage is critical, but it's not enough. The core issue is value. The core issue is not getting care to everybody. The core issue is providing the best possible outcomes for the money we spend. This is the fundamental challenge. We can't just keep putting more and more money in the system to try to do more and more things. We have to think now in terms of value. Patient outcomes per dollar spent. We have to evaluate every single thing that's done in healthcare delivery against this goal. And we have to ask ourselves, have we organized a system to deliver the greatest value? Have we organized a system that can improve the value over time? This is the question that I've been thinking about now for almost a decade. Now, this seems like a sort of perhaps maybe an overly futuristic way of thinking. But what I've come to believe is that the problem we're having in healthcare is that our efforts to reform the system are incremental. We've been taking little steps, and that's true in Finland as well. And we've been creating reforms that are often creating parallel structures and an additional reform here, an additional reform here. That way of reforming a system ultimately cannot succeed, in my opinion. We have to step back. We have to think holistically about the overall system. And we have to ask ourselves, what would a very high-value system actually look like? Suppose we didn't worry about the way it looks like today. Suppose we didn't start with the way it looks like today. How would we actually design a healthcare delivery system if we wanted to provide the greatest value for the patient? The patient is the center of a high-value healthcare system. It's the patient value that we're trying to achieve. How would we organize a system if that's what we really set out to do? And we've got to realize that the way the system looks today is the result of history. It's the result of the way medicine was practiced 20, 30, 40, 50 years ago. So we just can't assume that incremental improvement is enough. Indeed, I believe that in order to achieve a high-value healthcare system, and in order to ever hope to solve the problems of healthcare that are facing many countries, we need actually a restructuring of the system. A restructuring of the system. We have to change the way that actually healthcare delivery is organized and managed and measured and reimbursed. We have to restructure. We can't just make incremental improvements. What I've come to understand as a management scholar and a competition scholar is that healthcare today is delivered with 19th century organization structures. The way we deliver healthcare looks like the way other services were delivered hundreds of years ago. But healthcare is frozen. It's frozen in a structure that it's inherited from the past. That structure comes from the way doctors are trained. Doctors are trained, by and large, in specialties. The healthcare system is organized around specialties. But from a value point of view for the patient, that doesn't really make any sense. But we've got a structure that we've inherited. It used to be that patients went to the hospital and stayed there for many days. Because there wasn't a lot of treatment and technology available 20 or 30 or 40 years ago. So now we have a hospital-centric system where the hospital is the center of the universe. But today, of course, it's an outpatient-centric system. The inpatient hospital stay is very short. In fact, for many procedures now and even surgeries, you don't even have to stay in the hospital. You go in for the day. So we have to reconceive of delivering of healthcare in this new world where the inpatient part is very small. We have to reconceive of healthcare where we have many, many services for many, many diseases that are quite technologically complicated, where expensive equipment is involved. And we can no longer design a healthcare delivery system like we would have in a different world 20 or 30 years ago. And we also have tremendous scarcity of physicians and other medical staff. And we have to use physicians to their higher use. Today, we are putting our doctors in an impossible situation in terms of delivering truly excellent care. We're asking them to do things by themselves. We're not organizing them in order to do things as effectively as they could. So we have to reconceive of the structure of the system if, in my opinion, we're going to make fundamental changes. We can't just make incremental improvements. Now, there's lots of incremental improvements today that are being proposed and discussed in healthcare delivery. So, for example, there's a big sort of quality revolution in healthcare. In our country, we talk a lot about lean, applying Toyota to healthcare. That's kind of funny, isn't it? Toyota to healthcare. And the idea there is we have to rethink the processes of healthcare delivery and be more systematic about the process of care. Well, yeah, that's a good idea. But if you have a better process, but you leave the structure the same, is it really going to make a big difference? I don't believe so. We've got a lot of efforts now to do a better job of managing drug use and prescriptions. We have a lot of efforts to improve safety and minimize errors. All those efforts are good. All those efforts are helping. But ultimately, we, I believe, need to change the structure. We need to change the structure and the way we think about delivery of care. In our country, we are also putting great faith in the consumer. The basic idea of many of our thinkers in America is that if we just give the consumer power, if we give the consumer more incentive, the consumer will change the system. This is so-called consumer-driven healthcare. Now, unfortunately, what that means in the United States right now is that the consumer has to pay more. So the idea is that if the consumer has to pay more, they will pay more attention to their care, they'll shop around more effectively, and somehow that will fix the system. I believe very strongly that the patient must be very deeply involved in their care. And one of the critical weaknesses in the current system is patients are not enough involved, and we haven't done a good enough job in managing the involvement of the patient. Having said that, no matter how much the patient has to pay, the patient can't change the structure. There's no way. So I think this idea that the consumer is the problem is really not the right solution. I believe that healthcare delivery has to change from within. It's not going to be some outside force. The physicians have to change healthcare. Doctors and nurses have to change healthcare, not some outside forces. But in order to do that, we're going to have to reconsider the way healthcare looks and the way it's delivered, and we're going to have to challenge some traditional assumptions that we've had for many, many years. And that leads us then to the role of competition and the market in the system. Now, I almost took this slide out of my presentation because I knew I was going to be in Finland. I almost took this slide out because I find that in some European countries the idea of competition in healthcare is a very uncomfortable idea. What we found is that in most other fields of human endeavor, competition is good. It actually allows for improvements in value. We in the United States have a lot of competition in healthcare, but what we see in the United States is that competition isn't working. In fact, in many ways, the competition we have in America is making things worse. What's the problem with competition, and what's the role of competition in healthcare? Well, the problem with competition today, in the US but also in many other countries, is competition is not aligned with value for the patient. In too many systems like the United States, the actors in the system can do well financially even if the patient doesn't do well. So for example, if you pay a doctor, like we do in the United States, to do surgeries, then if they do more surgeries, they get paid more. The doctor can succeed and get higher compensation even though maybe all of those surgeries weren't necessary. You can see how in the current system in many parts of the world, competition is not aligned with value for the patient. We have the very critical distinction in thinking about competition that we need to introduce, because I believe there does need to be more competition in the Finnish system. But we have to avoid the mistakes that have been made in other countries. The fundamental problem we see in other countries, including the US, is that we have zero-sum competition. We have competition to shift cost from one party to another. We have competition for one party to grab more revenue or increase their bargaining power. And that competition actually doesn't benefit the patient. What we need in healthcare is we need competition that actually encourages improvement in value and rewards the organizations that could actually serve the patient better at lower cost. And that kind of competition we haven't yet created in the United States. It's the kind of competition that if we can create will actually help. And what I believe is these principles apply no matter who owns the system. Competing to improve value is just as important for a publicly owned system as it is for a privately owned system. What we need in healthcare is we need to start thinking about value. We need to start thinking about how we can improve the value. We need to get patients to the providers who can actually do the best job of providing value. You heard the Prime Minister a minute ago say that there are tremendous differences across hospitals and across clinics in terms of just the cost, much less the quality. We have a system now where we're not taking advantage of the power of competition to motivate improvements in value. We have to consider how to introduce competition as a tool if we can make it work in the right direction. All these things will be necessary, I think, if we're going to actually make a significant improvement in the Finnish system or in any system around the world. So what would a high-value healthcare delivery system look like? If our goal was to get the best possible health outcomes for each patient at the minimum cost, how would the system look? What would we do differently? Well, what I'd like to outline is a series of basic principles of value in healthcare delivery. These principles do not come from the theory. They don't come from business. These principles come out of the medical literature. These are things we already know, but we actually haven't applied them very effectively yet, given the historical legacy nature of the system. Let me very quickly talk about these principles of value in healthcare delivery, illustrate them with some examples, and then I'd like to talk about what some of the implications might be for Finland. If we really, really wanted to have the healthcare system in the world that demonstrated the best outcomes per dollar across the board for patients, what would we do here in Finland? What would you do in order to make progress in that direction? Now, the first principle is pretty simple, but in many ways the most important. The first principle is that we have to define value for patients as the goal. And what I find is very few healthcare delivery organizations have this goal. They have access as the goal. They have volume of services as the goal. They have various kinds of other goals, but the value isn't the goal. You know, how many hospitals in Finland can measure the value that they create for every patient, whatever that patient's disease? The outcomes that they've achieved versus the cost that they've spent. How many hospitals in Finland can actually measure the value that they deliver? And the answer is not very many, if at all. There's some research studies that look at these questions, but this is not something that's routinely measured and compared by organizations in healthcare, and that's true all over the world. We think in terms of access. We think in terms of volume of services. We think in terms of serving our local community, as if that were enough. Access is not enough. Access to care that is not as good as it could be is not a good goal. We've got to focus on value as our fundamental goal. We've got to start to learn to think that way about everything we do in healthcare delivery. And we've got to move beyond sort of simplistic thinking to improve value. In our country, everybody is sort of saying, well, if we just reduce the waste, if we just reduce the administrative costs, somehow that would make the system work. Well, the answer is that's not going to be enough. It's not waste there. Yes, there is waste. Yes, there's administrative cost. But those are very small compared to the actual cost of delivering the care. We've got to define the goal as value. Everybody's got to be united around the goal of value. And as we'll see later, we're going to have to learn how to measure that, and we're going to have to learn how to measure that a lot better. Finland's making some progress, but it can move much, much faster and much, much further. Second kind of key concept. If we really want to control the cost of health care, then there's really only one way to do that. You can't squeeze the salary of the doctor forever. You can't keep reducing the cost of drugs forever. That's a loser's proposition. The only way to truly reduce cost in healthcare is actually to drive up the quality. To drive up the quality. Where quality is actually the outcomes you achieve. Look at the points on this slide. If we really want to reduce the cost of healthcare, what we need to do is substantially improve the quality. As the Prime Minister said, we need to do a really good job of being efficient and effective in prevention. That could reduce the cost, but look at how that improves the quality. You avoid being sick in the first place. Early detection. We know that for many diseases, if we can detect them fairly early, they're relatively easy. Breast cancer is a good example. Stage 1 breast cancer, very high cure rate. Stage 3 breast cancer, big problem. Very hard, very costly, very difficult. If we really want to save cost, we've got to drive up the quality. Getting the diagnosis done right. Studies from the U.S. and some of our leading centers suggest that as many as 15 or 20% of all diagnoses are flawed and not exactly correct. I was at MD Anderson Cancer Center a few weeks ago, and they see a lot of very difficult cases in cancer. And about 4 or 5% of the people that come to them with a cancer diagnosis, they tell them at the end of a day or two, guess what? You don't have cancer. Because the quality was poor and the local doctor hadn't seen enough tumors and didn't interpret the tissue samples and the scans correctly. If we can get the diagnosis right, think about how that dramatically improves quality. That's how we lower cost. Starting the treatment early and doing the treatment quickly. The longer you're treating a cancer, the more likely you're going to have issues of resistance to the drug. You want to get that treatment done. You don't want to have to interrupt the treatment because of complications. You want to be timely. You want to move things ahead. That improves dramatically the quality outcome for the patient. That's the way to reduce cost. Get the right treatment to the right patient. We have lots of therapies that only work for a small percentage of the patients. And we waste so much effort giving a patient a treatment that doesn't work, and then we have to do the next one and the next one and the next one. And so on. Less invasive methods. Managing the patient after their recovery so that they don't have a relapse and don't have to have an emergency visit in the case of many medical conditions. We are not organized to drive up the quality. We're not organized to do these things. In fact, in many cases, it's very complicated and difficult for healthcare delivery professionals to actually spend a lot of time and effort on these things because of the way the system is organized. And we'll talk about that in a minute. The greatest thing we have working for us in healthcare is that actually better health is less expensive than poor health. If we can get people to stay healthy, if we can restore their health quickly, we'll be better off than if they have serious problems that we have to deal with for year after year after year. We know this from studies of many medical conditions, diabetes, asthma, cardiovascular disease. If we can do a good job and we can keep people healthy, that's fundamentally the way to get that value to go up. We've got to organize ourselves We've got to manage ourselves. We've got to measure ourselves in order to achieve these things. And at least in our country and in many other countries I've studied, that's not the way things are particularly structured. It's not that doctors are not trying to do these things. It's just that it's hard to do them. It's hard to do them the way we are currently structured. I believe that in order to drive value improvement, providers should need to compete for patients. Whether they're a municipal health center or a municipal hospital or anybody in the system. Why? Because the way to really improve value is to get patients to the provider who can do an excellent job. And we want those providers to grow and serve more patients. And we want the providers that are really excellent not to just be located in one location to serve just one community. We want the providers who are really good to expand so they can serve many patients. There's no reason why in Finland there shouldn't be healthcare providers that operate across the whole country if they're really excellent at delivering care for diabetes or delivering cardiovascular care or doing orthopedic care. Again, we've got a very local mindset in healthcare, not just in Finland, but all around the world. The whole idea we have is every local region should be self-contained. Every provider should just operate in one place, serve that little community. But from a value perspective, that really doesn't make much sense. What we've done instead in healthcare is we try to lift all boats. In America, we probably have 5,000, 6,000 community hospitals spread across the country. They're small. Many of them don't have enough volume of services in any given field to be really excellent. But we try to preserve all 6,000 hospitals and make each of them just a little bit better by exchanging processes and guidelines and so. But that model is not going to get us to a high-value system. We have all these little mom-and-pop kind of small organizations trying to reinvent the wheel, rather than kind of organizations that are truly excellent who then grow and serve more and more patients. We have a problem in healthcare that everybody tries to do everything. You know, pretty much every municipal hospital offers all the services, with very few exceptions, in every facility. And that doesn't make any sense from a value point of view. So we have to think about how to create a kind of competition. Not a competition necessarily for profit, but a competition at least for patients. So that patients can get to the person, to the team, to the group that's best equipped to serve their particular medical needs. And right now, of course, in Finland, we're not organized that way. We're not organized that way. That's not to say that we don't have good physicians. That's not to say that we don't have a healthcare system. But what if we wanted to dramatically improve the value? What if we wanted anybody in any part of Finland to have access to truly the world-class care that we could deliver? How would we do it then? That's the question I'm asking you to consider. And I know that some of you are starting to get frustrated and saying, oh, you know, he doesn't understand, you know, we're a good system, we provide good care. Of course you do. That's not the question we're discussing. The question we're discussing is how can we go to a whole another level in healthcare delivery? And the answer is we're going to have to question some of these practices and assumptions we've had in the past. Now, if we wanted to deliver high-value healthcare, how would we organize hospitals, physicians, and practices? And this is another kind of fundamental change that I believe is inevitable in healthcare. Right now, we are organizing practice around specialties and interventions and types of care. Outpatient is different than inpatient. Primary care is different than specialty. Radiology is different than surgery. Surgery is different than internal medicine. We're organized around specialties and around interventions. If we're thinking about value, that doesn't make any sense. It doesn't make any sense to organize that way. Why? Because that's not how value is created for the patient. The patient doesn't get value created by a surgery. It's not just the surgeon. What happens before the surgery has a big impact. What happens after the surgery has a big impact. We can't just think about the surgery as the unit of value. It's actually the whole process of care of that patient that's the unit of value. And so what we believe is that instead of organizing around specialties and interventions, we have to organize around the patient's medical condition over the whole cycle of care for that medical condition. Now let me give you an illustration. This is an example from Germany. And Germany, of course, like Finland, has universal insurance. They have a different organization of their system. They have health plans that compete and that are independent. And they have a provider structure that's sort of a hybrid. There's some government-owned and some private, and they all kind of work together. And they're all really part of the same system. Let's look at migraine care. Migraine care is an important problem in Germany. The outcomes of migraine care in Germany are very bad. The studies that have been done suggest really unsatisfactory results. Many patients miss many, many days of work. The evidence is that the drug prescriptions that many patients have are not the right prescription. There's a lot of new kinds of variations of drugs that can control migraine better, and many patients don't have the right one because they haven't been to a physician who could get them there. Many migraine patients have to go into the hospital when they have acute episodes. So there's a lot of evidence in Germany that migraines are very expensive and the standard of care is not very good. How does migraine care in Germany look like historically? Well, it looks like it does in the United States. It looks like what's on the left. There's a bunch of discrete units that are involved in providing that care. Most patients would start with a primary care physician. That primary care physician then would look at them. The primary care physician may or may not know anything about migraine. You know, they'll know a little bit. All doctors do, but they may not know very much. They might be interested in migraine. They might know a lot. It's kind of an accident. Whether the patient shows up with a primary care physician that actually is an expert. The primary care physician, particularly if he or she doesn't feel that they're able to deal with the problem, will refer to a neurologist, an outpatient neurologist. How will the patient find that neurologist? Well, it's going to be, a process by which the doctor will probably recommend somebody. So the patient then will have to call the neurologist, make an appointment, wait. Talk to a new administrative apparatus, get the appointment, and then they'll be seen by the neurologist. Well, then the neurologist will look at the patient. The neurologist is more likely to be an expert on migraine, but not all neurologists do this all the time. But they're more likely to be an expert. So they're going to look at the patient. They're going to say, well, given what I see, I think you better get a scan. So then what happens? Then the patient has to figure out, how to get that appointment. Go have the scan done. Wait. And then hope, and again, the scan will come back. Now, that imaging center may not take many pictures of heads. The radiologists in that imaging center may or may not really be very experienced in looking at those head scans to see if there's any problems. Some of them might be really good, some of them may not, but it's kind of luck of the draw. So then they'll go back to the neurologist. The neurologist might say, well, look, you might need some psychological counseling. A lot of migraine issues have a psychological component. Or you might need some physical therapy because it's been shown that migraine can be significantly improved by the right kind of exercise and other physical activity. In some extreme cases, the patient might need to go into an inpatient detoxification process because the root cause is really drug dependency that they have to get off. So again, the patient is a ping pong ball. pinging back and forth from one specialty or intervention to the next. Each of the lines on this chart is a coordination or a referral. And what happens is that many of the coordinations are very, very limited. There's not deep information exchange between each party. The people don't necessarily work together every day. They may or may not know each other. Everybody's really busy. They're rushing through their appointments. They write a few notes. They may send a letter. There's not a deep coordination going on here. Nobody has time. Nobody has the resources. Nobody has the staff to really kind of sit together and talk and understand what's wrong with the patient. They all see the patients. This process is sequential. You do one, then you do the next, then you do the next, then you do the next. It stretches over a relatively long period of time. That's healthcare delivery for almost every medical condition in almost every country in the world. That's the way it looks. If we were trying to deliver high-value care, we would do it very differently. We would do it the way it's done on the right. Once the patient was identified as having a migraine issue or a serious headache issue, they would go to, and this is actually exists in Germany, the West German Headache Center. There are now multiple units of the West German Headache Center in different parts of the country so that they're more accessible to patients depending on where they live. Now, instead of having separate facilities and separate services and separate appointments and separate administration, we have an outpatient-centric care model where we have the key skills working together in the same organization, in the same building, every day. Neurologists are, of course, the key players. Psychologists are there. Physical therapists are there. And there's also the capability for kind of a day hospital process where the patient will come in for several days and go through a comprehensive sort of therapeutic process involving these specialties and group activity and so forth. If the patient needs an image, the image will be done next door in an imaging unit that's very, very good at looking at head scans, and who these people working in the headache center actually know and work with all the time. If the patient needs a detoxification, they will go next door into the Essen University Hospital, in this particular case of the first unit, whatever the partner hospital is, and they'll be cared for by the same neurological group that is staffing the outpatient center. So that it's the same doctors that will be carrying inpatient or outpatient. Once the patient has a therapy that seems to be working, then they will be referred out to a network neurologist. This is a neurologist that has an affiliation with this center, that's committed to be an expert on migraine care, that shares a medical record with the center, where there's a seamless transfer of information and diagnosis and recommendations. And the network neurologist will then manage the patient, or actually send the patient back to the primary care physician just for routine health maintenance if everything seems stable. Very different model of care. The model on the left is organized by specialty and by intervention. It's a sequential process. The model on the right is organized around the total medical condition. And it involves all the specialties working together in a coordinated way in the same organization to deliver high-value care. This model has produced dramatic improvements in patient outcomes. The percentage of patients who have days off from work goes down dramatically. The number of days of lost work goes down dramatically. The number of patients whose migraine is not well controlled goes down dramatically. And guess what? Even the cost goes down dramatically. Because what this does is it avoids the acute episode. It avoids going back to the hospital when your migraines are so bad you can't stand it. It avoids all the repeat visit after visit after visit if the migraine isn't controlled. So if you allow about a year to go by, you start to actually not only dramatically improve the outcomes, but lower the cost. Because we've reorganized care delivery around value, not around the traditional structure. Now, in order to do this, we've got to think not around specific episodes of care, but around the entire cycle of care. The entire cycle of care. This is a very complicated picture. But what it does is it kind of lays out the cycle of care for a breast cancer patient. And the breast cancer patient needs a lot of different things done over that cycle of care. Some of them are diagnostic things, some of them are interventions, some of them are recovery and rehabilitation, some of them are ongoing monitoring. There's testing, measuring, all these things have to be done. Right now, the way we're organized, each of these things is done by a separate unit or many separate units in a process that's not truly integrated. What we need to do is move to an organization structure where we really organize around the medical condition of the patient, not around the way the physicians have traditionally organized themselves around specialties and interventions. That's the way to dramatically improve value. We've got to get experts working together as teams and really taking responsibility for the patient over the whole cycle, not just responsibility for their particular intervention, whether it's the surgery or the office visit or reading the scan or looking at the path tissue sample. We've got to reorganize the way we think about healthcare delivery. And I'll come back later to talk about the patients that are complex with multiple medical conditions. Here's another example in cancer care, MD Anderson Cancer Center. Typical community cancer care is you have in a community, you'll have some medical oncologists, you'll have some surgeons that are general surgeons, and you'll have some radiation therapists. And the patient will go to one of those at a time, and they'll go through an arduous process of trying to deal with their cancer. And the typical doctor will see multiple types of cancer. At a place like MD Anderson, which is now moving towards a very, very high-value model, what they will do is instead they'll put all the team to look at a particular type of cancer in the same organization. This is just an example of their head and neck center. These are physicians and skilled people. All they do is head and neck cancers. And people come from all over the country, but again, remember, they're not in the hospital very long. They're only there for a few days. They get their radiation therapy and their chemo back home. But in terms of the evaluation and the complicated things like the surgery, they come to this center. The head and neck center has oncologists, surgeons, therapists, dentists. All these people on the left are dedicated to head and neck cancer. That's all they do. That's all they do. Those are the kind of tissues they look at. Those are the kind of tumors they look at. Those are the kind of operations they do. It's a very complicated area because of the disfigurement issues, because of preserving the voice, because of the need to coordinate the surgery and the dentistry. It's a complicated area. They've got a dedicated unit that works together as a team day after day in a shared facility to serve these patients. They get extraordinary outcomes. And they can do it very efficiently. They move the patient very quickly. The patient comes for an appointment, and they can see all of these people at once on the same visit. It's all coordinated by a staff nurse who is a triage nurse for the visit. If they get looked at when they first come for their appointment, they get seen by a social worker. If they look upset, if they look like they have additional needs, then they'll call for additional needs. They might need some nutrition issues. They might need some psychological counseling. They take responsibility for this patient's care throughout this whole care process. That's how we need to think about delivering care if we want to achieve extraordinarily high value. Some facilities are shared, but really the core team that's responsible for the patient's success is dedicated. We can see the same kind of structures in diabetes care, and this is just an example from the Joslin Diabetes Center. We need to change the organization of care. That is going to be critical to making a substantial improvement in value. That means, if we're going to do it that way, that every facility can't treat every condition. Because we're going to have to get enough volume and scale in order to allow ourselves to do it right. And that reflects another large body of literature in medicine, and that is that volume and scale and experience matter in healthcare delivery. And that's what we call the virtuous circle. If you see enough patients and you can develop a lot of expertise in a particular medical condition, whether it's congestive heart failure or certain kinds of cancer care or diabetes care or asthma care or orthopedic care, if you can see a lot of patients and get enough volume, you can start to learn faster. You can have a dedicated team. See, one of the wonderful, interesting things about healthcare from an outside perspective like mine is, in healthcare there are very few dedicated teams. A team comes together sort of almost by accident for a particular patient. But if you've got enough volume, you can have a dedicated team. You can have the anesthesiologist working with a surgeon every day, doing a particular type of care for a particular problem. You can have nurses who become expert in that particular set of issues if you have a dedicated team. You can have tailored facilities. You can design the facility to make it really efficient to care for that particular problem. If you're going to try to care for every problem in the same facility, you've got to sort of have general purpose shared facilities. If you've got enough volume, you can have a dedicated facility. At MD Anderson, there's an entire outpatient unit, it's huge, for head and neck cancer. Everything they need to provide that care, all the test equipment, all the kinds of diagnostic rooms, it's all there. Everybody's there, they're working together. And they can do that because they see enough of those cases that they can afford to have multiple surgeons and multiple medical oncologists that do nothing else but that. And they can design the facilities accordingly. If you've got enough volume, you can start to subspecialize. If you've got enough volume of cardiac surgery, somebody can start to be really great at valves, and somebody can do the CABGs, and somebody can do the signaling issue problems that people have with their rhythm. You can subspecialize, and people get even better. When you have dedicated teams, you have somebody to talk to. So many physicians are practicing largely on their own. And they're not dealing with expert colleagues in consulting and coordinating because they're kind of lone rangers. They have to deal with all the problems of a certain type in a whole region. Again, we've got to take advantage of the value improvement that comes from experience and scale. We can no longer have this hyper-fragmented system that we have today. If you look at Finland, you all know the data for Finland. A large percentage of care is provided in units that only do a little bit of that care. And that's true in the United States. That's true in Japan. In Japan, the typical heart surgeon is doing like, 1 or 2 operations a week. You can't do 1 or 2 operations a week and truly be excellent. And you can't have a dedicated team that you know how to work with and that it's used to dealing with those problems. So we've got to deal with this problem of fragmentation. And we should no longer think that every facility has to do everything. Today, it's much easier for patients to travel, 50 miles or 75 miles. Maybe 50 years ago, it was hard. And we designed a very local system because of the realities of the patient. But since the patient is going to only be doing an inpatient complex procedure for a few days, maybe it's a good idea to build in a different structure in terms of getting the patient to a place that's very, very well equipped to deal with whatever problem they have. Because we're so fragmented in healthcare delivery, and this is certainly true in the U.S., it's true everywhere, though. Because we're so fragmented, there's extreme duplication of services, there's poor utilization of equipment, and there's a tremendous tendency for a lot of shared units. So you have an imaging department that's shared among every possible kind of imaging, so that the radiologists have to do a little bit of everything rather than become really, really fantastic at a more limited set of activities where they can truly achieve excellence. And so we've got to find a structure that sort of reorganizes this process. We're starting to see this happening. We're seeing it in the U.S. We're seeing it in some other countries. Here's an example of a children's hospital in Philadelphia that now is not just a single hospital. Some of you have heard of CHOP. It's one of our leading pediatric centers. My friends in Boston Children's would get mad at me, but I think CHOP is just as good as Boston. CHOP is not just a standalone children's hospital. As this slide illustrates, it runs inpatient pediatric care in 4 other hospitals covering an entire region. The same staff, the same team is staffing the central hospital and the hospitals out in the surrounding area. And the care is coordinated. A child is placed near home if that's good enough, and if that's going to be more convenient because they don't require the facilities of the downtown hospital, but they come downtown if they need something very, very complicated where there's not enough volume in the community in order to achieve the levels of excellence that they're trying to achieve. They don't see themselves as just one self-contained hospital. They see themselves as part of a network where they're integrating. And there's a division of labor. This location does this location does something else, that location makes different choices, and they coordinate with each other and see themselves as part of one integrated team. That model we're starting to see more and more put in place as the providers start to rethink the value that they're delivering in their model. Third fundamental principle of a value-based system is that value must be measured and ultimately reported. And we need to do that not for the system as a whole. Yes, we can do that too. But the really critical place to measure value is not for a hospital or not for a clinic. The critical place to measure value is for dealing with a medical condition. Because that's, of course, where value is created. If we try to mix cardiac care and cancer care and orthopedic care and create very broad measures that measure all of those things at the same time, then we're not going to do a very good job. What we got to do is we got to measure how well we do in terms of each medical condition. Not just an episode, but over the cycle of care. We don't want to know just what happens after the surgery. And we don't want to just understand the complications of the surgery. We want to understand really the whole care process of how that patient did and how fast they recovered and how much return to function they were able to achieve and whether they were able to sustain their recovery for a long period of time. And what we find is in most countries we are simply not measuring value. What we're measuring mostly these days is process. We're measuring whether doctors adhere to guidelines. There's been a proliferation of guidelines, and the idea is that doctors have to follow these guidelines. And so it's kind of checking the box. Did you prescribe the aspirin within so many minutes of patient presenting? Did you do this? Did you do that? Did you do that? We're trying to control the system by measuring how doctors do their job. That's a disaster. Guidelines are good, but they're not the way to try to measure success in the system. The way to measure success is to measure the outcomes, to measure how well the patients do, and that's what, by and large, we're not doing in most parts of the world. In terms of measuring value in healthcare, every patient starts with some initial conditions. There's some process of care. Often, in some cases, they're indicators of how well the patient is probably going to do, like HbA1c in diabetes care. That's not an outcome. That's an indicator of expected outcomes. And then there's the outcomes themselves. Did the patient survive? How complete was their recovery? Did they have relapses and complications and so forth? And what we really haven't been done been doing in healthcare is we haven't been measuring the outcomes. We've been focusing on these other things in most parts of the world. And Finland is made progress on measurement, but has a long way to go. In measuring outcomes, we also have to start to learn to think more systematically about outcome measurement. To the extent that we measure outcomes in healthcare, what I found is we measure one or two things about a particular kind of medical condition, like survival in cancer. In cancer, the kind of bread and butter measurement is about 5-year survival. And 5-year survival is important. Obviously, it's of fundamental importance. It's probably the most important thing that we care about or any patient cares about. But ultimately, there's a whole set of outcomes. Some have to do with the health status of the patient. Some have to do with the time to recovery. Some have to do with how difficult and arduous the care was, and we want to try to make that as little as possible. Some of those have to do with how sustainable the recovery is, how long the recovery lasts, whether there's a relapse or a recurrence. And we're just starting to understand how to think about the set of outcomes that are required to really understand how well we're doing in dealing with a medical condition over the cycle of care. And very few providers and very few healthcare systems are really approaching this measurement challenge. But if we don't measure how well we do, if we don't measure the success of care over the cycle of care, it's going to be very hard to get better. And it's going to be very hard to help the patient find the provider that they need. This is just an illustration of this framework in breast cancer. And of course, we have to control and try to measure initial conditions, adjust for risk. There's a lot of concern about how hard adjusting for risk is. This has meant that we've been very, very slow to measure success in healthcare. But again, the science of risk adjustment is exploding, and we simply have no choice in healthcare. If we really want to move to a higher value system, if we want to get better results, we're going to have to learn how to measure those results. We're going to have to learn what factors make it difficult to achieve those results. That is a critical part of the learning process. And it's a part of the learning process that we must begin. And there's some principles in this presentation which I'll make available to everybody that's interested that we can look at. So let's kind of talk about a couple more principles, and then we can turn to Finland. Fourth principle is that the way we pay for healthcare delivery must be aligned with value, and it's got to reward innovation. If we want a high-value system, we've got to have the reimbursement model fit with value for the patient. In many systems, reimbursement takes one of two forms. A very common form of reimbursement is you pay for each service. So you pay something for the surgery, you pay something for the office visit, you pay something for the scan, you pay something for the drug, you pay something for each service that's provided. What's the problem with that? The problem with that is actually that works against value. Because that creates a motivation to do more service. And it creates a motivation not to reduce the service. So if you're paying for every service and the doctor does a great job, and instead of having to see the patient once in their office, they have to see them, instead of seeing them once, they avoid having to see them 5 times, they only have to see them once. Then all of a sudden the doctor says, I'm not sure this is a great idea, so I'm not going to spend too much time trying to think about that. Another way that we pay for healthcare is we have global budgets. So there'll be a hospital will have a budget. And the budget will either be for everything, or the budget might be by department. And the hospital will, and the hospital will maybe get a little bit more money if they provide more services in the month or in the year. But usually they're penalized if they go over their budget, in terms of the volume of service provided. That's another way that care is reimbursed. You tend to see that often in Germany, for example. Neither of those models really reward value. The way you want to reward value is you want to pay a provider one price for the care for the whole medical condition. You want to pay the provider one price, and then the provider is responsible for providing the full care. That includes the inpatient, the outpatient, the office visits, the drugs, the images, everything. One price. And that's what the patient ultimately and what society should care about. How was this patient cared for and for this medical condition over boundaries that are defined? How well did the patient do? Did they recover? How quickly did they recover? How completely did they recover? Did they have relapses? And then how much did that whole thing cost? We spend a lot of time haggling over how much should we give to the anesthesiologist, how much should we pay for the drugs, how much should this be, how much should that be, how should we divide? And that's actually not relevant for value. Instead, we want the experts to decide how to spend the money. We'd like to give a team a certain amount of resources and then give them the responsibility to say, okay, how am I going to spend this money? What's the best use of this money? Maybe I should spend more on rehabilitation because that'll get me a better result. I'll have fewer follow-up visits. Maybe we should spend the money on more preventative type activity so that if you're going to have an orthopedic surgery, maybe we ought to have a 3-month period before the surgery where we're putting a lot of money into getting the patient to lose some weight. Because if the patient loses a little weight, the operation is dramatically more likely to be successful and go well and have fewer complications. So we want the experts to decide how to take the pool of money to deal with this medical condition and use it the best way and innovate and do things without the need for more work than necessary and do things in ways that are less invasive and less complicated. But right now, the reimbursement system is either neutral or negative for value. Today, the reimbursement system really doesn't reward innovation the way it is today. And I think fundamentally we're going to change that. This is actually happening. You may think that this is a little bit radical, but it's actually already happening. For example, in organ transplantation now, and in the U.S., there's a single price that covers the evaluation, the surgery, and the immediate convalescence. And that's because the health plans and the providers decided that that was an area where they could come together and that would be in both of their interest to move away from the traditional kind of fee-for-service model and move to a model where there was a single price where if the provider did a great job, they were motivated they would benefit from that job. If we can do this in transplantation, we can do it everywhere. And we're starting to see a whole series of examples where we're moving to this notion. I call it bundled pricing. You get a fee for the entire service, not separate fees for all the subparts of the service. That aligns the interest of everybody with value. And by the way, if we reimburse that way, the patient could go anywhere in Finland, and wherever they chose to go would get that price. And so the public-private distinction would go away. You wouldn't have to worry about whether it was a public facility or private facility. It wouldn't matter if you reimbursed that way. And everybody would then be motivated. That must have been a radical suggestion. Everybody would be motivated to improve value. Again, I'm asking you to suspend history here and say, how would we do this if we actually wanted to create the best possible environment for the goal that I think we all have, which is to improve value. Now, A fifth principle of value is we need information technology in order to achieve these changes in structure and changes in measurement. And of course, Finland has been actively trying to improve information technology, and you're making a pretty good progress. And some of the new laws, I think, are promising because they're starting to be more forceful in terms of kind of making sure that we have electronic medical records permeate the system. To have a really world-class information technology system for healthcare delivery, what do we need? We need not just to automate the way we do care today. Let me say that again. We don't just want to automate the way we do care today. We need to restructure how we do care and make sure that the information technology supports that new kind of care. So in order to achieve that, what has to happen? We have to have common data definitions. There have to be definitions of all the diseases, of all the symptoms, of all the treatments that are common across the entire Finnish system. Everybody has to mean the same thing when they say, asthma, phase 2, or whatever the disease is. They have to mean the same thing when they're talking about a particular treatment or intervention. So we have to have common data definitions that everybody has to follow. We have to have interoperability standards so that every system in everybody's office and every hospital can actually talk to each other. Again, if you believe that value is created in the care cycle, everybody that's involved in that care cycle has to work off the same information. We can't have the surgeons having different information than the folks that are doing rehab or the folks that are doing something else. We need a common information platform. It's got to be accessible and compatible across the whole system. We need patient-centered databases. All the information for a given patient has to come together in one place in a way that you can see it and look at it and see what's changed. We need the information system to include all types of data. Text, images, test results, all have to come together in one place. We need the information system to cover the full cycle of care. The nursing homes have to be part of it. The primary care has to be part of it. The hospital has to be part of it. The specialist offices have to be part of it. And finally, it's got to be accessible to all parties on a reasonable basis given issues of confidentiality. So the referring physician has to be able to see what's going on later, because that patient may come back and they're going to need to know what's going on. The rehab provider has to have the notes from the surgeon. We have to have all the players involved in the cycle of care involved. Now, the problem that most countries have with information technology is that there's too many flowers blooming. Too many little efforts in each region, each hospital, and things don't come together because there's not been an agreement on the standards and the fundamental principles that are going to define the system. I would humbly suggest that Finland's got to be more forceful. Not in forcing anybody to necessarily do any particular thing, or but at least in defining these standards and putting in place a deadline so that organizations will sort of get on with this challenge, and creating, if necessary, financing mechanisms if budgeting issues are a problem in terms of investing in this technology. And I think Finland is off to a pretty good start, but hopefully can move the next level. If we believe in value principles, providers of healthcare look different than they do today. They're organized around integrated practice units for each medical condition. Many providers will have multiple integrated practice units. They'll have a cardiac unit, they'll have an orthopedic unit, they'll have a cancer unit, and they might have subunits. But we move away from the specialty structure. We move away from inpatient, outpatient. We move away from that old model. We move into integrated practice units. Second, each facility chooses its services based on value. Every hospital, every clinic doesn't try to do the same thing, doesn't try to do all of everything. We actually design a system where each facility fits into an overall integrated practice model. And the people working in those facilities are no longer separate people. They're people that are working as part of a team in a given medical area. We integrate services across geographic areas. We don't see a rural hospital as a self-contained entity anymore. A rural hospital shouldn't possibly try to do everything. They have to provide emergency care. They have to stabilize patients. They have to be involved in some of the services that need to occur near home because that's much more convenient, and those services are intensive in terms of the number of visits. But the rural hospital needs to see itself connected to other provider organizations for doing complex and more intensive activities. Again, Finland has started moving in this direction, but I would say you're just beginning. Just beginning. Different providers and different facilities don't just have kind of professional referral relationships. They actually develop partnerships and alliances so that they know each other, work together, have a common sense of protocols and how to work and how they're going to handle things. I think that we're going to see a tremendous advance in the use of remote technology. I was in an emergency room in California about 2 weeks ago in a general hospital. And in the emergency room, they had this robot that had a camera instead of eyes. It had camera. And it had a big screen on its chest. And it could move around. Because depending on the child that came into this facility, the robot could move to the part of the emergency room where the child was going to be cared for. And this robot was operated by an intensive care physician at a children's hospital that was 25 miles away. A child was brought into the emergency room of the general hospital, taken care of, obviously, by the staff there. But unless it was a very routine case, the general hospital would fire up the robot. The doctor in the intensive care unit at the children's hospital would look and see all the data and look at the measurements and consult with the staff in the general hospital. And, for 1 out of 10 kids, the conclusion was, get them over here. Get them to the children's hospital. Get them to our intensive care, our emergency room. But for 9 out of 10 cases, the local staff that dealt with mostly adults, but a few kids, could deal with the situation. Now, how were they able to do that? Because that doctor in the children's hospital saw himself as part of the team in that emergency room. They had a relationship, they talked a lot, they had protocols, they had ways of working together, and that facilitated the use of remote technology to take advantage of the fact that ICU doctor in the children's hospital could actually had enough time. It just took him 4 or 5 minutes to look at these patients and make a judgment and use his expertise. But he was much more skilled than the people in the general hospital were in that area. Those kind of things can proliferate. But not until we reorganize care, not until we start to build integrated practices, not until we have teams that get to know each other and work together and see themselves as part of a care delivery network, not a bunch of isolated, standalone units delivering care. The implication here is to expand excellent teams across geography and let the excellent teams care for more patients. And then you get the virtuous circle, because as you get more patients, you can get better facilities, you can get more subspecialization, you start to get the value machine starts working in your favor instead of the fragmented structure we have today. We've got to measure, we've got to think about new contracting models, we've got to get on with electronic medical records. Again, just some more examples of providers integrating across the geography and doing some of the things I've said. In a world of value, health plans, or in the case of Finland, the municipal health department, has to see their job differently. Traditionally, the health plan or the payer sees themselves as a payer. I'm the one who pays the bills. That's not a value mindset. Instead, the health plan has to think of itself as adding value, not just a payer, through collecting information about the patient, through ensuring that the patient's overall circumstances are looked at. No one doctor or no one hospital may have the total picture of the patient. The health plan has to kind of pull all this together to kind of see if they can understand the overall circumstances of the patient. Helping the patient get to the excellent provider, advice and counsel, to get the patient to the right place. Assisting in coordinating care where multiple providers are involved. These are value-added roles of health plans. These are roles that municipal health departments could play, but all around the world they don't do that. All they do is pay the bills and try to beat down the cost and negotiate lower prices, and they don't add value. They just try to drive down the cost. And that's a lost opportunity. It's not that you don't have to be efficient, but we can add more value if we have value as our mindset. And remember, the best way to reduce cost is really to drive up the quality of the outcomes. And so the municipal health department ought to be in that business, not in the business of cost reduction and paying the bills. Employers in Finland have a significant role in healthcare through the occupational health system. In the long run, it's not at all clear why we should have a separate system. I'll come back to that later. But I think that what we've come to understand now in America, finally, is that actually employers should care a lot about the health care. Because the biggest cost to employers is the cost of poor health. That's a huge cost. In America, we find that the cost of poor health, absenteeism, presenteeism, where the employee shows up at work but they're really not there, they really can't be productive. The cost of poor health, estimates show, is 3 times the cost of the actual health benefits. So it's a real mistake to try to reduce the cost of health benefits if what you get is more poor health. So our employers now are understanding that they have a tremendous ability to influence the lifestyles and health activities of their employees. So more of our employers are doing what you do. They have on-site clinics. They have on-site health clinics because they want their employees to be able to get that checkup without taking a day off. They want to have screening, disease management. They have all kinds of healthy living incentives. And I think Finnish employers could take their thinking about health care, again, to a higher level. And understand that they actually have a big stake in the health of their employees, and they actually have some influence over their employees' lifestyle practices and if they really think about their job differently. Consumers or patients in a high-value system, play a different role. In the current system, many patients are pretty passive. The doctor is kind of king. They go to where they have to go. They go to the local municipal hospital because that's where they have to go. They go to the health clinic because that's where they have to go. They go see the doctor they've been assigned. They're kind of passive. What we know is that healthcare, of all the products that I've ever looked at, is the product where there's the most, if you will, synergy between the patient and the doctor or the provider. We know that no matter how good a job the doctor does, if the patient doesn't participate, comply with their care, take care of themselves, the doctor can't be successful. We've done a poor job in really mobilizing patients to engage in their own health. And that's because none of us have time. Doctors don't have time to call the patient every 2 or 3 days and check up on them. We don't have good systems for making sure the patient is taking their medication, even though we know that if they don't take it, they're going to have problems. We don't have good processes for engaging the patient, and the culture of patients and the culture of doctor-patient relationships is often working against this kind of a partnership model. And so I think there's a lot of opportunity in Finland and almost every other country to kind of find much better ways of creating better patient engagement, better patient compliance, simply compliance with their therapy in many cases. Government has to set rules and create policies that support value, to encourage and support the restructuring of care that's necessary. And again, there's not a lot of time to talk about the details of government policy in general, but what are some of the key things the government has to do? Government has to make sure that there's a universal outcome measurement system. That just can't be a bottoms-up thing. It'll take too long. It'll be too inconsistent. It'll go too slowly. Government has to make sure that IT standards are set. It's well understood government has to do this in telecom or fax machines, things like that, but somehow in healthcare, government has tended all around the world to hold back here and be very respectful. But ultimately, government has to, working with the medical societies and the medical profession, really get on with this agenda. Government has to make sure that it sets rules that allow restructuring of delivery. Government needs to rethink the way it's paying for care. Government needs to think about how to use competition judiciously to actually improve value, and so on. So, I just want to emphasize before I talk about Finland that these principles that I've been talking about are not theoretical. Everything I've said, literally every word I've said, is being lived every day by leading providers across the world. The organization, the reimbursement, the measurement, the IT, all these things are being done. This is already starting to happen. It's starting to happen because usually physicians have figured out that this will allow them to do a better job, to actually provide better care. And it might make life for physicians better. Because instead of being a solo physician having to pretty much do things for yourself and work on your own and do a lot of administrative stuff that is hard to find time to do, that this kind of model and this kind of thinking would actually give physicians a chance to actually achieve, first of all, more productivity, but also actually more satisfaction. Because they could actually deliver true excellence. Now let's talk a little bit about Finland. What are some of the implications of this for Finland? And then, of course, we'll hear from other speakers and Juha later on to talk a little bit more about this. We are still thinking. We are still studying. We are still developing our thoughts. And so one of the reasons this session today is very important to me, and one of the reasons I'm here, is that we're very anxious to have a dialogue. But at least from a preliminary point of view, some of the key implications for Finland look like this. First, Finland has already got some examples of moving to the integrated care models, the integrated practice units. They're working pretty well. We need to drive that model much more deeply into the Finnish system. We've got to eliminate artificial distinctions between health centers, hospitals, long-term care facilities. We've got to find a way to start to drive integrated practice. Putting the specialties together, building teams that work together, that are supported by the right information, and so on. And this means that the geographic locations that we have should no longer be seen as islands, isolated islands, but we need to start to stitch them together. Finland would benefit from a value perspective by starting to do a better job of coordinating care across the public, private, and occupational systems. Right now it feels like duplication. Right now it feels like another complexity that makes coordination for a given patient difficult or duplicates services. We've got to think about how to create a structure which harnesses all of these facilities and all of these medical experts and physicians, because we're going to need all of them. We're not talking about shutting down anybody or not having people practice. What we're talking about is making sure that we've designed a system that takes the maximum advantage of these to deliver the best care. And right now the system seems to be a bit cumbersome, and there's a little bit of unnecessary complexity. Number 3, there's no doubt that Finland has to limit the duplication of service lines across providers in order to reach threshold volumes to allow excellent care. Not because physicians aren't trying hard, not because they're not talented and well-trained. It's just physically impossible for any human being to do too many things at the highest level of excellence without the right support staff, without the nurses, the support, and the facilities to actually allow that to happen. This will have a dramatic impact on productivity and quality. We have a lot of facilities in Sweden that just do a few of something, and we've got to start thinking hard about moving more aggressively towards some thresholds. That's already started in Finland. You've put that thinking in a few areas. I think it's very important, though, that there's some competition. So as we rationalize, we got to make sure that ideally there are more than one center in each medical condition. And if there's only one, then we've got to make it really easy for patients to go somewhere else, to Sweden or somewhere else. Because, again, we need to have patients fundamentally have a choice, in my opinion, of what provider is going to best serve their needs. And so we need to maintain some competition in the system, even as we avoid duplication. I would certainly believe, and this may be unthinkable, but I believe that there's no reason, from a value point of view, not to, and indeed there's strong value arguments for opening up provider competition for patients across municipalities and across even the hospital districts in Finland now. From a value perspective, we want patients to get to the excellent providers. From a value perspective, we want the excellent providers to do more. We have situations in the U.S. now where there's a hospital in Newport Beach, California, but another excellent provider actually operates part of that hospital. So, for example, in Rochester University Hospital in Rochester, New York, the Cleveland Clinic operates the cardiovascular surgery practice. You have the world-class Cleveland Clinic running a subunit of a hospital in another city. Okay, that's the kind of models that we're going to see proliferating in healthcare. Rather than to have each facility try to do everything all by itself on a standalone basis. So as we open up competition across municipalities, I think there needs to be more interesting kinds of partnerships among the various municipal hospitals in different parts of the country, and between the tertiary hospitals and the more community hospitals. Linking up, connecting around medical conditions in order to achieve true excellence, in order to integrate care, in order to get patients cared for in the right setting with the right facilities. These kind of things can and I think should proliferate. Excellent providers of care should be encouraged to expand their services across geographies. Now, what does this mean? What this means is that a physician that's right now doing orthopedic surgery in a municipal hospital in some part of Finland may actually not do that anymore, but they're not going to go out of the business. We need every doctor, every single one. Instead, that doctor that's now doing it by himself in a rural hospital is going to join and become part of a team of a much more substantial organization that does orthopedic surgery. And think of how exciting that is. Think of how exciting it is to actually have the equipment, the expertise, the facilities, the information systems, the measurement systems, the colleagueship, in order to join that excellent team and improve the level of practice. That's the kind of thing that we're not talking about doctors getting out of medicine. We're talking about putting doctors in an environment, in a structure, in an organizational model where they can actually enjoy and be highly productive and extremely good at what they do. But right now we are asking doctors, I think, to practice under circumstances that are very, very difficult from a value perspective. Of course, the primary care system is fundamental to value, because a lot of the most high value activity in healthcare is preventative activity, it's screening activity. The problem now is our primary care system needs to be re-engineered a little bit around value principles. We need the primary care to not be a separate island. We need each primary care facility to be very closely tied into specialty facilities and to build a network of partnerships so that it can have integrated care for its patients. We need primary care practices to start to create subspecialties so that one clinic will develop real expertise in diabetes care, another clinic will develop real expertise in asthma care. Yes, maybe patients might need to travel a little bit more, but it'll be worth it, because the patient then will become part of a really expert team with the right nurses and the right therapists and the right equipment really to deal with that problem. Ideally, we need to create a reimbursement structure around care cycles so that wherever a patient is cared for in the system, the reimbursement really follows that patient, and that provider is really motivated to do the best possible job. But of course, that provider's results are going to be measured. And that will make the competition based on value. Of course, we need to expand outcome and cost measurement, particularly at the medical condition level. That needs to take place for every patient. Every patient that's treated by every provider, needs to be measured in terms of their outcomes. And we're a far cry from that at this point, but we can get there. We need to set some IT standards and accelerate the development of IT in Finland. Right now, the IT is good. There's some good pieces. We haven't stitched the system together. We haven't made the choices necessary to do that. The municipal departments of health need to become health organizations that add value, rather than see their role as simply payers. And we need to figure out a way to inform and equip our citizens to be more integrally involved in their health and their health care in every way we can. One of the advantages of integrated practice units is that if you've got such a unit and if you've got enough patients, you can afford to have people, nurses or others, that actually spend a lot of their time engaging with patients, calling them, checking to see if they're doing what they're supposed to be doing. And part of the problem that we've had with patient engagement is that nobody has the time, nobody has the resources to actually do it. These implications, and some of these are, I think, directions that Finland is already going. I'm just arguing we need to go faster. Other of these implications are perhaps a little bit more radical. But in any event, what I would urge us all to do is let's reimagine healthcare delivery, and let's think about how Finland's system can not only be excellent, which it is now, but truly world-leading by really rethinking the whole process of care delivery. Well, thank you very much for your attention, and we'll look forward to the discussion that's going to follow.
Very much. We are about to, if we have the discussion after Juha's presentation, so as one entity. Yeah, thanks. This was something like not throwing a small stone on us, but handing over a rock. Take over, please. Thank you very much, Dr. Porter. We are exactly on schedule, and therefore I have to postpone the discussion of this presentation so that we will have only one after Juha Teperi's presentation. But now I'm sure everybody needs a cup of coffee, which we spent half an hour, so we will be back here at 20 past. And then Juha will give his presentation, and then we talk. Thank you very much.